as we get toward the end here, let's kind of talk about what do you do in clinical practice. So you know, again, I think we have to reemphasize that comprehensive genomic testing at the time of diagnosis is important. We talked about the clinical profile of the ALK patient, where you should be highly suspicious and don't accept a negative FISH if you have this suspicion. You should go to either IHC or next-gen sequencing to diagnose it. We've agreed that alectinib is the kind of first-line choice at the current time, although, you know, obviously this is a rapidly moving field. Patient may be on alectinib for a couple, 3 years. How do you handle, what do you do at the time of progression? We obviously have choices like ceritinib, brigatinib, lorlatinib, and even in selected situations, you would advocate bringing back crizotinib.
So what I would do at the time of progression is get a ctDNA, and I realize that the utility of this is debated, and this is my just personal opinion.
That's what I want. I want your personal opinion.
And so I'd get that. Then I think that you want to see that ALK mutation. I think particularly if you see the G1202R, you're a little bit more inclined to lorlatinib. I think the more, and then if you don't see any mutations, you might think a little bit more about chemotherapy. And so I think the question is, we don't really have good data, so it's going to be very patient dependent in the situation. I do try and get tumor biopsies, and I think we've touched on this earlier. The other mistake I sometimes think we're making is we're so enamored of these new drugs that if patients really have oligo progression, I really try and extend the treatment life of alectinib at this point. I mean, I think that's, we can't be too enthralled by the newness of these.
Right. The role of blood-based testing, you think, is the reasonable way to start?
I think it's a reasonable way to start. I think, just to give you some historical context, we've tried the tumor testing with the ALK and the FISH and the IHC, and we're clearly not getting to the level we need to as a field in terms of compliance. And I think we need to move to, like you do, tumor and ctDNA, I think we really need to do this. I don't even think it's a patient or physician education. I think we've just hit the practical limits of tumor testing in terms of the adequacy of the biopsy, the techniques that we have. And so we really need to sort of expand our options for testing.
One of the issues that clinicians often face in clinical practice is, you know, within 2 or 3 days, they might have a PD-L1 result. You know, I encourage clinicians to ignore PD-L1 status until you know the genotype of the patient. What are your thoughts in general about immunotherapy in the ALK-positive population?
So one of the things we emphasize is genomics trumps PD-L1.
Yeah, absolutely.
I mean, I think that's got to be sort of our...
That's my slide.
It's my slide. I think it's something that we really need to iterate, because, like we talked, the enthusiasm around immunotherapy is exuberant right now, and I think that's great. It's been a tremendous advance, but the EGFR and the ALK patients really don't benefit from single-agent therapy. Response rates around 5%. You might see 10 in one small series here or there. And so I don't think single-agent...
The durability of those responses is not very long.
No, and these
it's not like you see the response rates of 70–80% in you know 2 to 3 years durability.
And I think the real question is chemotherapy alone or chemotherapy with immunotherapy.
Right.
Your trial of carboplatin, paclitaxel, bevacizumab, atezolizumab allowed patients who had been previously treated with ALK-TKI.
To date, the only trial other than IMpower 130 did allow those patients on. But to your point, I think that the take-home message here is this is not a population that derives any significant benefit from immunomonotherapy. So if you see those patients, I've actually had a couple patients either with ALK or EGFR who had PD-L1, you know, of 90%, and the outside clinician or the referring physician was about to start immunotherapy, and then lo and behold, in the most recent one I had was an EGFR mutation. And the question from the community physician was, what do I do here? And I said, well, it's pretty obvious what you should do. You should give them targeted therapy in that, because they're much more effective. The IMpower 150 data did include a small number of ALK. It's hard to really draw conclusions based on small numbers. But I think the important point is trials like Keynote 189 and others excluded these patients. So you really can't use that data set to draw conclusions.
I think it's an important point. I think
Yeah.
that there's, because you know, we really want to have evidence of benefit.
Yeah. And of course, you know, we've had a nice discussion about the plethora of TKIs in this setting, but again, pemetrexed-based therapy can derive great benefit for these patients in this setting.
Yeah, I think it's important to, the chemo versus the Empower 150 is generally, the carboplatin and pemetrexed, it's the chemo I offer, or I offer the Empower 150
Yeah.
to the patient. Those are my two options. I don't offer the Keynote 189. I have a feeling I'm
Right.
in a minority.
I think you might be too, because I've heard that this is what people would do, even though when you point out that they were excluded from that trial, it doesn't seem to matter. To me, it matters, but yeah, it's either carbopem with or without bevacizumab. But if they're eligible for bevacizumab, I would favor the Empower 150 approach and do that.
Oh, well, we've talked a lot about testing. I think the other challenge that we sometimes face is the false positive. Yeah, I mean, and I think that this is something where if maybe a patient doesn't fit the typical profile, I think that secondary testing is really critical, because then you may initiate a therapy that's inactive and do this patient a disservice. And
right.
so,
and I think most of the false positives occur with FISH testing.
Yeah.
Right? Yeah. I think that's a great point. Particularly if you find what's called ALK-positive on FISH, and there may be another driver that's there. And I had a case several years ago where the patient had a KRAS mutation, but was also called ALK-positive. And when I spoke to Sonia Dasik at UPMC, she said, I had to call it. I don't believe it. I believe KRAS, but I would ignore that ALK thing. So I think you do see some false positives.
Yeah.
So this has been a great discussion. Anything emerging or new that you're excited about?
Well, I think there's two other phase 3 trials in the frontline setting, ensartinib versus crizotinib and lorlatinib versus crizotinib. And I think that this leads us to the potential we may have, 5 or 6, next generation LTKIs as first-line therapies. And I think that's where the toxicity profile, and we're going to have to do the dreaded cross-trial comparison to really think about it. But it's great to have a wealth of options for patients these days compared to 2011.
Well, this has been a great discussion. I want to thank you, Dr. Skinscombe, for your insightful discussion, and thank you to our audience for watching this targeted oncology presentation on ALK-positive non-small cell lung cancer.